And to see her here 2 years later, pain-free, insulin-free, working, and organizing a feat like today, this is why I come to work every day, Sonia. And I am wearing purple in honor of this patient because all her post-op appointments and today, you note she's wearing purple for the pancreas, and I see your nails are also purple. So it's my greatest pleasure to introduce Sonja Arellano.
And here I thought I was going to get through this without tears. Like they said, my name is Sonja Arellano. I was diagnosed with acute attack of pancreatitis sometime in the month of May of 2010. Prior to that, though, my entire life I've suffered with GI issues. The age of 2, I was at the Children's Hospital here in Minnesota for a large intestinal bleed from a birthmark. That started my journey with Mom being told I had acid reflux, I had GERD, I had a sensitive stomach. Just pay attention to what you feed her, she'll be fine. Went through that all through school, high school, was a very strong athlete, but would miss games and things because I just wasn't feeling good sometimes, not ever knowing really why. Drank Maalox, Tums. I ate them like they were candy. My grandfather had acid reflux, so I just figured it was, part of the genes, part of the family traits. I was on the pool deck at the Blaisdell YMCA here in South Minneapolis. Realized that there was something terribly wrong. I started profusely sweating. Got a felt like I was just going to vomit in the pool. Obviously, I didn't do that. I ran to the locker room. But before I could leave the pool deck, I had to get relief. I had to get another lifeguard on the deck. I was the only one on deck. So I have to call for my relief, who was still 20 minutes from having to take the pool deck. She grabs the pool deck for me, which thank God she did. I go into the bathroom. I vomit violently. I thought I was done. I got dressed. I was getting ready to head to Edina, to the Y in Edina. I taught swim lessons there. Luckily, the front desk person didn't let me leave. He made me sit down, and within 10 more minutes, I was legitimately in the fetal position on the floor. They're calling 911. I'm being brought to HCMC with my first acute chronic attack. Was released, kept in the hospital, was released the next following day, ended up in the Buffalo Hospital for an entire week. At that point, they said, it's pancreatitis, you're just going to have to deal. I said, okay. A couple of years later, my husband lost his job, lost our medical insurance, so therefore no more treatment, no more help for anything, no pain, none of the nausea. I'd go to the emergency room because here in Minnesota, luckily they have to see you whether we have insurance or not. Racked up thousands upon thousands of dollars in medical costs that way. Thank God for 2014 when the Obamacare or the Affordable Care Act, whatever you want to call it, came into effect, because my primary care doctor in Buffalo at that time, which was Dr. Robert Mullaney, brought me to a wonderful man here at the University of Minnesota, which is Dr. Freeman. In 2014, I seen him for the very first time. He looked at me and said, well, we have several options for you. Let's first start with stenting. We did, I believe, 3 or 4 stent procedures. The first one worked fabulously. I thought I was cured. He thought he was the greatest man walking on this earth. Still think he is, but a little differently now in a different way. That stent lasted a full year of relief almost. I made the mistake, like 3 days before the year mark, of looking at my husband and saying, I think I'm cured. 3 days later, I started getting nauseous again. Started feeling the bubbling, the pain, the swelling. Went back to the doctor. No, Dr. Freeman said, let's do another stent. We did. That one fell out within like a week. We did one more. That one stayed in for about the time you wanted it to. I think it was like 3 or 4 weeks, and then we had to go in and physically remove it. Then we tried to do one more, and at that point, Dr. Freeman said, we're done. We can't continue to stent this anymore on you. I also have pancreatitis, which, did that contribute to it? I don't know. The actual full-blown cause of the pancreatitis was a gallstone in the common bile duct. They also cut my sphincter of Oddi, thinking that that would help relieve some of the complications that I was having. It didn't. He then relayed me over to the transplant team, and that's when I got to meet Dr. Bielman, and then introduced to Dr. Bielman once I was approved to be a part of the TP-IAT family. I also am a part of one of Dr. Bielman's research studies. I did receive a medication prior to my surgery to help assist the islets in implantation. Is that the reason why I'm doing so well today? We don't know yet. We'll do my 2-year checkup with her next month. With my 1-year or my 2-year checkup that I just had with Dr. Bielman, he said that I'm doing great. Like Louise told you, I am back working. I work currently with an assisted living facility in St. Cloud, Minnesota. I help take care of 170 at this point seniors who I highly advocate for with their health issues because I know how it feels not to be listened to. I have several residents who, because they're older, are diabetics. Try not to be compliant with your insulin with me. It doesn't happen. Had a resident come in, was non-compliant. Needless to say, 4 weeks that he's been with us, his blood sugars are now in the normal range. He thanks me every day for helping him. I tell him every day it's because of the University of Minnesota that I'm able to do what I do today. I do let everybody know at my job that I work with and advocate for the National Pancreas Foundation. They at the facility are extremely proud of me. I've worked at this facility now since November, and February I was, and still am because it's February, the Employee of the Month. That's a really big step for me because I started working again in 2018. I had an 18-month hiatus in employment. I started working originally at 14. Hadn't had any hiatus from 14 up until that 18 months. To get back to work was amazing. I hate sitting on my butt. I've never been one to sit still. In high school, I did softball, basketball, swim team. Now, I am currently doing the National Pancreas Foundation. I'm working, and I'm helping take care of my husband because 3 months shy of my post-op, we were in a horrible car accident. Louise got a call from my husband at the accident scene saying, I don't know what to do. She's on her way to you. Luckily, they did not let me know this at the time, but they honestly thought that the accident had killed my transplant. I was told at my 1 year that I didn't have a real high islet yield. I still don't honestly know what that islet yield was. I don't really care because currently, unless I get put on steroids, unless I choose to carve out, I don't have to use insulin. When I went to the state fair last year, I took insulin with me just to be safe. Luckily, I didn't have to stick myself. However, I should have probably stuck myself a couple of days ago when I chose to do a Shamrock Shake with a Big Mac and a large fry. Woke up the next morning, my blood sugar was still kind of high. We won't send you that reading. Normally how I do my eating, and for those of you with children that will eventually have to deal with this is, and it may be not appropriate, and I'm not a doctor obviously, but I eat 2 hours later, I'll check my insulin levels, my glucose, and if it's higher than where they want it to be, which is 120 or lower, I will choose to use insulin at that time. But technically, I'm insulin free. I've got a life. I live it. I walk my dogs again. The only thing that I haven't been able to do so far that eventually I hope we'll be able to do are my 50 sit-ups again. I haven't been able to do 50 sit-ups truthfully in many years because of the pancreatitis. I mean, even doing any abdominal exercises was horrible. It was like I heard from the talking about your Allison or whatever, where didn't want to move. Yeah, 18 out of 24 hours a day I laid on the couch or in my reclining chair now. When it got to the point I couldn't lay on my left, I couldn't lay on my right, I couldn't lay on my back, I slept in a reclining chair. It was easiest. I could prop a pillow or the heating pads on whatever area was hurting at that time, and that's how I slept. My body today wakes me up every morning at about 5 in the morning. I use the facilities, not constantly, but it's a continual 3-hour period every morning where I'm constantly using the facility for bowel movements. But that's relatively a small compromise for what I can do now. I work a second shift job, so luckily I'm up for a few hours. I take a nap before I go to work. Napping are my friend. So we might have to discuss why I shouldn't nap during the day when I do it. Okay. So naps are good again. Okay, that's great. I have had a couple of pictures, but I'm not sure if they were able to be downloaded or not, but I have them on my cell phone if you guys would like to see them, of all my different aspects of my body. I went from being 180 pounds prior to surgery. After surgery, going down to 124 pounds. I'm currently averaging 138 to 142. I, my entire life, honestly never knew that this part of my abdomen was supposed to be small. Always had a bump. I never knew that the only part that should be down here. When you see certain pictures, I've never had children. I knew by 10 years old that I was not going to have kids because I didn't like how I felt as a kid. So I didn't want to pass this on. I didn't know if it was, I had also learning disabilities that I didn't want to pass on. And I'm glad I didn't, because I don't know if I carry a genetic mutation. And God forbid, I see the pain in your faces watching your children. I couldn't imagine, because I know what I went through. And being as healthy as I am, I've got a big mouth. I want to speak about this. I want people to know that we can come together and make a big difference. And eventually, if this is your outcome, you have to get the little, I don't know, I think I got like a 6-inch scar. I've got a second belly button. From the feeding tube, that's what I call it, is my second belly button. But it's a small price to pay. I can't thank anybody enough for going to school to do what you guys have done for me. The doctors here are phenomenal. If you're second guessing where you're at, stop. You are at the best place possible. Dr. Freeman, Dr. Beelman, Dr. Bellin. I didn't get a chance to work with Dr. Guru or any of them, but my team, Louise, have just been phenomenal. I wouldn't ask for a better care team. I still go to my primary care doctor, who is in Buffalo, Minnesota. I live in Little Falls. So for those of you who are from Minnesota, Little Falls and Buffalo are still 72 miles apart. I will travel the 104 miles or 114, whatever it is, to see that man. Because without him, I wouldn't have found Freeman. Without Freeman, I wouldn't have got Bellin. Without Bellin and Beelman, I wouldn't be me. And now I'm me. We're going to keep the National Pancreas Foundation in my life. We're going to keep it in Minnesota. And we're going to get more active with Minnesota, the U of M here, and whoever else I can get on board on our team. That's what I intended to say today. I really appreciate everybody here. Dr. Freeman, you are a godsend. I thank you. Thank you.
Hi, I get to introduce the godsend. He is the chief of adult GI here at the University of Minnesota and a professor of medicine as well. He is also the recent recipient of the Lifetime Achievement Award as part of the American Pancreatic Association. So it is my distinct pleasure to welcome Dr. Martin Freeman.
Well, that was pretty amazing, Sonia. I can't thank you enough. As Louise said, you and everybody here are the reason why we come to work every day. And it's the reason why I really love working at the University of Minnesota, because I really think everybody here, every medical professional in every capacity here, we all share the same mission. And that's why I moved here 10 years ago full time. And so, what else can I say? So let me just find my talk here. So what I'm going to do is take you through a little bit of where endoscopic therapy fits in, and any of those who know me and have had to sit through conferences know I have some pet peeves. And as I get further on in my field, it's really about integrating care of pancreas to the entire patient and not focusing on one procedure or one surgery, one procedure, one whatever. And this is endoscopists trying to tackle pancreas disease alone, or surgeons trying to tackle it alone, or pain doctors. You have to work as a team because every now and then things will go okay until you hit a turn. This is the team here I'm so privileged to work with, and what I really, really think is wonderful is the way we integrate adult and pediatrics. This is sort of 50-50 here. This is not just for this conference. This is what we do every day. We share expertise back and forth. And it has so many benefits. So what is chronic pancreatitis? Well, it's really a syndrome, not a disease. It's a continuity from recurrent acute to chronic. And mechanisms of pain are really many. And there's various mechanical things. I think endoscopists focus too much on duct obstruction. But there's many sources of pain, and as Matt pointed out, there's central sensitization and neuropathic pain. One thing, and take this with you, and if any of you ever has to go to the emergency room again and are told, like Dr. Schwarzenberg said, that, well, they didn't believe you because your lipase was normal or your imaging is normal, this paper here is the best study to show that chronic pancreatitis pain and pattern and severity are independent of an abdominal imaging finding. What does that mean? That means that we get patients who have amazing burden of calcifications in their pancreas who have no pain. Typically, it's older patients with idiopathic disease, but we have some PRSS1 hereditary patients with massive burden and no pain. But the flip side is if everything looks normal, it can be pancreatitis, and don't let, even expert pancreatologists tell you, well, everything's normal, you can't be having pain, and your pain, isn't real. You heard that from Matt, but this is scientific evidence, and this is the second of two papers that show that. This is from the North American Pancreatitis Study Group, and we just had Dheeraj Yadav here. He was our visiting professor this year, wonderful researcher in pancreas disease. So what do we do about pain? And notice I'm not just telling you about endoscopic therapy, because it has to fit into, I don't like subdividing treatment into endoscopic versus surgical. So that's why I'm trying to give you this in context. What do we do for pain? Well, alcohol and smoking cessation, enzymes, antioxidant, analgesics, blocks, spinal cord stimulator, pain clinic. Pain management should not be done by gastroenterologists. Okay, I see this all the time, along with their stent, the prescription. ERCP, stone fragmentation techniques, and then surgery. So what is endoscopic therapy? Well, the goal is usually duct decompression, closing leaks, but I'll show you there's actually many facets. Stents are not actually the therapy. I hear this even from our surgeons in our groups. It's not generally stent therapy. It's opening the ducts, closing leaks, removing stones, and improving strictures. Shockwave lithotripsy to break up stones, and then endoscopic ultrasound. I'm going to show you the most exciting part of endoscopic intervention now is actually EUS. So this is a list of all the things that we do endoscopically, and notice that stenting is one of 9 here. So what is stents for is actually to treat strictures. Now I can tell you this is a child with PRSS1 disease with diffuse multiple strictures, big duct stricture, big duct stricture. First of all, I'll tell you off the bat, this is never going to be, if this patient's symptomatic, which they are with current pain, stenting strictures like this will never lead to long-term outcome. But if you're going to do it, bigger is better. Multiple stents is better. This is another patient, an older man with hereditary pancreatitis who refused surgery. First thing I did, I said, you need surgical intervention. He would not do it. I had him see Greg Bielman multiple times. So as a second best, we did dilation stenting of his stricture. But what I see over and over again is single stent put in. If you're going to treat a stricture, you either need very big stent or multiple stents. Unfortunately, now the new vogue is going to be covered metal stents. And the problem with and this is a paper just recently out from an Italian group about treating dominant strictures. And the problem with that is that will enable community gastroenterologists to say, oh, I can do this now, put in the stent. And rarely is the problem just a stricture in the head. These also occlude side branches, and they cause stricturing at the upstream end. So there may be, and I have treated a number of patients with these in very select situations, but I'm afraid this is going to unleash a wave of over-aggressive stent, because we're seeing it in the bile duct, over-aggressive use of covered metal stents even in cancer patients or suspected cancer patients. What about extracorporeal shockwave lithotripsy? This is a dialysis patient from 20 years ago at Hennepin who had severe, huge calcification in the pancreas due to renal failure, dialysis, and not a surgical candidate. With intractable pain, and how do you get from that to an empty duct with nice drainage is, at that time, there was only one way, extracorporeal shockwave lithotripsy. And we've been working with our urologists for 20 years to do that. I'll show you an alternative to that. But the other big step forward, and I'm very proud to work with Sean Mallory, who is with us at the U, the head of our endoscopic ultrasound team. We together 15 years ago reported the first use of endoscopic ultrasound to access pancreases through the stomach, place a wire through into the duodenum so that you could grab that wire and get up into the duct and place a stent or remove stones or do whatever. And Sean actually, I like to joke, it's sort of like when Al Gore sort of implied that he invented the internet. Sean Mallory actually did invent the rendezvous, which is now a standard technique. But the most exciting thing, it's very risky and tricky, but done well, it's essential. But the next step to rendezvous is what I'm really excited about, and this is something we just developed in the last 2 years, which is patients who have isolated little segments of upstream duct that can't be, usually after necrotizing pancreatitis, like our first patient showed you, where they get relapsing pancreatitis in the tail. The only options for them is total completion pancreatectomy, splenectomy, islet auto transplant. And while that's a great option for some patients, it's not for all. And the question is, how do you drain that little duct into the stomach safely? Now, the technique was described 20 years ago for drilling a big hot pottery hole into the pancreas and putting a big stent, and you can imagine that that's like hit and miss. If you miss, big trouble. So what we've done is think small, tiny needle, tiny wire, borrowing angioplasty balloons. We found one from the interventional radiology suite, and putting tiny little stents in backwards. Here's the stomach. Here's the pancreas, and this is this isolated upstream segment of pancreas, and here's the little backwards stent that wants to curl like fingers hanging into the duct. So we've now done 8 of these, and I want to actually, it might be, instead of showing you more data, I want to actually show you this, because this is the thing I am most excited about that is the biggest advance in endoscopic therapy, I think. And this is actually a 34-year-old med student who had all his care at Mayo Clinic. He has a familial polyposis syndrome, had his whole colon and rectum out, had his ampulla out for ampullary tumors which go with it, then got necrotizing pancreatitis, which was treated there very nicely through the endoscopic technique that Guru described. But then he developed painful pancreatitis in the tail with a very short segment. Now, the only surgery, and he has no other pancreas left, the only surgery you could offer him was to remove the rest of his pancreas and his spleen, which would leave him diabetic without an islet auto transplant, a bad diabetic. He'd already lost his colon, his rectum, most of his pancreas, and now we're talking about spleen. But this, what I find really gratifying is Mark Topazian of Mayo's Advanced Endoscopy Center realized Mayo's given up their islet auto transplant program. They had one briefly and they've dropped it. And so they couldn't offer him anything but a brutal pancreatectomy, and he had he's a wonderful guy. He had the integrity to think, well, there's another option, send him to Dr. Beelman. So Greg, and this is how we roll here, Greg, very logical to do a distal pancreatectomy with splenectomy and an islet auto transplant. But the patient was really reluctant because he's lost a lot of organs. He's 30, he has 3 kids, 2 of whom have familial polyposis. So he's got, and he's a med student. So he, it's not, and so he comes to the University of Minnesota. We have our weekly group meeting on Wednesday. And Greg says, well, it'd be perfectly justified, take out his pancreas, but do you guys have another option for him? And so we actually invented this technique for him, and we've now done it. We've done it in 8 patients. And the idea is that you picture this little tiny segment of duct, which is actually greatly magnified here through the stomach with endoscopic ultrasound. But when I showed this video to the Belgian who developed this technique with big devices, cautery 20 years ago, he said, no way would he do that. And here's the scope is about as big as your thumb, so you can see that this is a very small segment of duct, but it's causing him a world of daily pain and recurrent pancreatitis. So we use a tiny little wire, a tiny little O18 wire, which generally smaller is thought to be less stable. It's actually more stable. And then the key to this is we borrowed an angioplasty balloon that's tiny from the interventional radiology suite to dilate a fistula from the stomach to the pancreas. And then we put in a tiny little stent here. Let's see if I can show you. You can see how small it is here, feeding that little tiny stent in. And the secret to this is you actually put the pigtail end first, so the pigtail grabs into the duct. Otherwise, it would just fall out and you'd have a leak. Anyway, long story short, guy comes back at he's now 2 years out. Here's the 2 stents. I went back and put a second one in. They act as a wick. You don't need to change the stents. And here he is 2 years out. He's doing great. And he actually switched from med school to PA school so he could stay, shorten his training and get busy and take care of his kids. So, and we've just submitted this series of 8 patients. But the doc from Belgium, who's viewed as the world pioneer, said he would never have tried this case because it's too risky with a small duct. So that's some of the nifty stuff we're doing, but notice how this patient got here. It's what I call right place, wrong, you get into the program, we'll do it. Now, honestly speaking, Sonia is a more common story. Come Dr. Freeman, he could do magic for you. Well, maybe it was magic for a year, but quickly move on to definitive treatment, which was total pancreatectomy out of transplant. So, and that's so commonly the story. You come here for endoscopic therapy, we'll say no. And so, you need pain management. I wish we could we have very strong adult pain people, but I just don't think it's to the sophistication and multidisciplinary breadth of Matt's program. And, but we do, we get everybody pain management, enzymes, medical nutrition, and then we'll get what's right for you. Now, I just want to say now, Varia Kirshner is here, and she's going to talk about surgical therapy, but this is still, I just want to give you the endoscopist perspective. There's a long history of surgery for chronic pancreatitis, and it's typically partial drainage or resection. And there were 2 randomized trials that showed that those old-fashioned operations, if you will, were better than endoscopic therapy. But they're kind of apples and oranges because they were mostly alcoholics with very large duct disease. And in those group, probably true, but that's less than 5 or 10% of the patients that we see with chronic pancreatitis. So the one size does not fit all for anything. So if you have a center that's relentlessly focused on TPIAT as the only solution or as endoscopic therapy, which I see all too frequently, that's a problem. So Bari's going to tell you about surgical management, but I want to show you a few cases also, right place, wrong reason, and also how we work as a team to figure out best case scenario. And I'm going to show you 3 PRSS1 patients with different presentation and different solutions, and 2 of whom didn't get TPIT and are doing well. So you don't operate on a gene, you don't operate on an X-ray, you operate on the patient and their symptoms and their trajectory. And then I'm going to show it, with permission of a patient who's here, show you a case where endoscopic therapy clearly the wrong thing to do, if you will. And that's, one of I've become crotchety old man, and that's one of my pet peeves is, pointless poking at the pancreas in practice, because it's become very vogue in the GI community. So let's take these cases. It's a 7-year-old girl with hereditary PRSS1, frequent hospitalizations, missing a lot of school, but unlike Malia, she had multiple little stones in the duct and not strictures. And I think that's the key difference. So at age 7, we did it. This is the small duct packed with stones, like peas in a pod, but no strictures. Took about 3 procedures, but we got all the stones out. And she'd gone from probably, similar to Malia to, to this, and she really did great. And we have hers and her family's permission to show you this picture. I wouldn't do it without their permission. And obviously we like cards like this, but that was 10 years ago, you can see, or 12 years ago. So she's had ERCPs every few years to clear out stones, but she's doing great. She's on the comp cheer squad. My daughter did comp cheer. It's insanely athletic, right, Sonia? Did you ever have any overlap with comp cheer? It's, but she's a flyer. But the point is, not all PRSS1 or hereditary, or they don't all need TPIT. You need to offer them a choice. She had very responsive, anatomic, and clinically responsive disease. Okay, fast forward, 17-year-old, this is just from a couple of years ago, recurrent pancreatitis since age 6, about attacks every 6 months, PRSS, same mutation, different kindred, identical twin who had a drainage operation at age 6, which actually in her sister's case kind of worked. So we don't recommend it, but it did work. But what she had was a huge cluster of stones in the head of her pancreas. And she was referred also from Mayo here by their peds GI docs for a TPIT eval. And again, saw Jenny, saw Sarah Jane, saw the whole team, or maybe this was Dr. Downs, I'm not sure, but presented her our weekly meeting. Not doing bad. She's a cheerleader too. I don't know if there's any connection with that, but doing well between attacks, not missing school, but then would be waylaid every few months. But she's got obstructive stone disease. So instead of TPIT, this is Guru and this is published now, it was one of our early cases of doing instead of extracorporeal shockwave lithotripsy, which actually didn't work, we did digital spyglass where we put a little tiny scope up into the pancreas and what I call turning snowball into snowflakes, taking this big obstructing stone and break it up under direct vision. And took a couple of those procedures, but we got her duct completely cleared out. And she's doing well. I actually see her and her sister together as joint appointments. So, why is she different, say, than Malia? I would never persist with ERCP. The only reason we even kept going with Malia and Sonia was, with Malia, because she was too little at first, and we had to just try to get her through to TPIAT. That was clearly the right thing, and to go to it early. And that's the theme we've learned about surgery. If somebody is heading towards surgery, do it early. Don't perseverate with endoscopic therapy. And the other is don't do partial operations if they're going to be a candidate for TPIT, because it kills their chance of islet yield, or it reduces it. It doesn't kill it. But then, and again, with Sonia, we went fairly quickly from endoscopic therapy to TPIAT and didn't perseverate. But so I just want to take you, and I think I'll skip the last case, who was a med student here who had a different genetic syndrome, who progressed very rapidly with stone disease. We never did endoscopic therapy, just went directly to TPIAT, and has actually gone on to a career in pediatrics, did research with Melina, and is doing well. That's where we just skip endoscopic therapy entirely. And I think that's very important to do. But I just want to tell you, if it's okay with your permission, 37-year-old woman who did drink but stopped a long time ago and has had multiple episodes of pancreatitis, is an insulin-dependent diabetic, so does not have an opportunity for islet auto transplant. That's out of the question. But then went to a big private group where they kind of, oh yes, we're going to treat that with ERCP. Had a failed attempt at stone extraction, a complicated 8 days course of pancreatitis and sepsis with H influenza, and then finally came here where she spent maybe 45 minutes talking to Guru. And the reason I want to make a case, and I hope it's okay that I'm showing this, it's not, and I hope that's accurate. One look at her CT here would tell you this is diffuse calcific disease. There is it makes as much therapy as sense for anybody, let alone a community doctor, to try ERCP on this as it would for me to do brain surgery. Like, it's not going to work. It's not that, it just can't be treated. This is diffuse calcific disease. So if one were to do intervention there, it would be Greg Beelman Fry procedure. And that's in fact what Guru recommended. He spent 45 minutes talking to her, I believe, and said, if anything, you need a Fry procedure. But even better than that, she's done really great with medical management, and it does not need anything. No more ERCPs, no surgery, medical management. And that's the best outcome. But the point of this is not charging into endoscopic therapy. And I just saw perhaps the worst case I've seen a couple of weeks ago with a 18-year-old with SPINK1 genetic disease from Texas who we'd seen at age 12, who had very severe progression of her disease but was subjected to a series of ERCPs by a very famous person down there and caused horrible complications without an exit plan or referral for ultimate goal, where clearly, if one looked at her severity of disease and symptoms, next step is TPIAT. No reason, just like here, no reason to do endoscopic therapy at all and skip all that. So that's just sort of my preaching. Everybody knows, who works with me, I'm kind of like getting to be crotchety. This is one of our, fantastic outcomes of TPIAT. Just to make the point, and this is not made up, 84 ERCPs at a very famous center in the Rocky Mountains. And this was years ago. They have now bought into the TPIAT process. But 84 ERCPs, told nothing to offer. Mother here brought her to the U. You'll recognize this person in the middle. And this is her after TPIAT. This is ridiculous. It's what I call ridiculousness in endoscopy. And I see this as a gastroenterologist, interventional endoscopist, become pancreatologist. I am now much more aligned with the NPF, the APA, than I am with the endoscopy societies. And, for that reason, I'm not as much of a favorite of their lecture circuit anymore for the endoscopy societies, because I say a lot of time, we're doing cutting edge stuff that frankly others aren't. Why? Because we do it when it's the only good option. The patient, all of our team, Chinny, Molina say, and Beelman say, there is no good surgical option. You need to do this. We're not doing it for sport. We're not doing it as a repetitive sequence, but it's part of a treatment plan, and we will skip it if it's not the best thing. And, she's another example. So we could go on, but let me just, again, hats off to Molina, because what she didn't say is This is an NIH-funded study that she's doing that it's very hard to get NIH-funded funding. There's only 3 trials in the U.S. that I'm aware of in clinical acute pancreatitis. And at the APA last year, I organized a symposium for Melina, Dr. Aliouch, who's the PI of the INSPIRE study, and Greg Cote, who's along with Dirajoutov, the PI of the other 3rd NIH trial that is on Devisum and pancreatitis, like Sonia, to show that there is finally now getting to be National Institutes of Health funding for major clinical trials. Melina is the leader, the inspiration for all of this study, and is exquisitely good at organizing in her nice, kind manner. Gets people to stay on task because it's like herding cats trying to run these multi-center studies. And this is how we're going to really learn about role of TPIT. What do we do here? Just to give you an overall spectrum, about 300 ERCP US focused on pancreatic therapy, and about 10 to 15 new pediatric cases a year. We do a lot of pancreatic stone work, but only when it's the best option, not tilting at windmills. And again, we vet all patients that are on the borderline through our team. We now do as many non-TPIT surgeries for I-Whipple distal as TPIT, which is really important because I'll never forget a shouting match between Suresh Chari at Mayo, I love, he's a wonderful man, a brilliant pancreatologist, and Greg Bielman. Suresh accusing Greg that we're a one-trick pony here at the University of Minnesota. We treat all the disease the same way. Not true. And I showed you a few examples of that. However, if you do, if that's the right thing for you, hopefully, as in all of your cases, we'll get that in a very timely fashion. So we have a Minnesota paradigm that's very different than classical teaching. I just spent the last month battling with international co-authors on an opinion piece on chronic pancreatitis that did not include total pancreatectomy as a pathway. It was basically your old-fashioned surgery versus endoscopy. I had to say in my gentle fashion, what is this, 1999 year or 1979? So this is our group again, and typically on any Wednesday, about half this group will show up. We have to, sadly, Ty Dunn, who was a wonderful surgeon, is now chief of pancreas transplant at Penn. So we lost her, but Guru, we need to Photoshop Guru in here. And then there's been a few other changes, but you can see Matt. By the way, Josh Wilhelm, he runs our islet lab. He's not standing on a stool. That's how much taller he is than me. And I'm wearing elevator shoes. He's, just in case if any of you, he's a giant in his field. What can I say? But, we're all a little bit loony here in Minnesota. It's a picture I took up north. But, part of it is about bringing up the new generation, taking care of not only patients, kids, but, I kind of view Guru as my medical kid, and I'm very proud to have trained and continue to train a lot, work with a wonderful team, Sean Mallory, in interventional pancreas GI, Sean Mallory, Guru Trichodenathan, Stuart Amato, who's absolutely wonderful, and then Nabil Azim, our newest addition, who's more branching into other avenues of interventional endoscopy, but is absolutely stunning. But we're only one little part of a team. We're not the ERCP clinic. We're not a GI clinic. We're a pancreas team. So anyway, it's been a privilege meeting, and I know a lot of you out there are patients and families. It's been a privilege to have you come here on a snowy Saturday. I see some other patients' friends out there, but it's really the highlight of my career is getting to work with everybody in this team, which are second to none. And, you know, I like to brag because I'm from the East Coast, but I try not to brag about myself. I will say, having visited Cleveland Clinic, Mayo, I've been all over the country. I've never seen a place with an integrated team where all aspects are as strong as here, and that's, you know, why I'm so proud to be here. Anyway, I should stop there. Thank you.
You have been disconnected from the meeting.